All right, now it's time for Dr. Ditoli. I think he's very well known in the community and around the country. He trained, it looks like he's a New Yorker, I didn't realize that. Trained at Mount Sinai and as well as Westchester County Medical Center, NYU for radiation therapy, and a fellow at Memorial Sloan Kettering. So we all kind of share a lot of the same pedigree. So without further ado, Dr. Ditoli.
Well, thank you for all coming. I'm going to be giving a sizable talk here, and as many of you have been to my talks, they often are, so it's good that they've printed it out. Anyhow, just check my pointer. Okay, moving forward. Who's at risk for prostate cancer? Well, there are pre-treatment categories, and you may not know where you fall, low risk, intermediate, or high risk, just to say that the higher you go, the higher your potential risk for failing the disease, with the highest risk being those having clinical T3A, 8 through 10 Gleason scores, and a PSA greater than 20. Should you be concerned? Well, perhaps, since 30,000 men per year will develop a biochemical recurrence following prostatectomy, and another 13,500 patients will develop recurrence annually following primary radiation, which brings us up to that 50,000 number approximately that Dr. Treeman alluded to. There's nearly 3 million men currently today living or having been treated for prostate cancer, and that number continues to grow. Most importantly, in a patient who's had treatment and who fails locally, documented local failure, 66 to 75% of men will develop bone metastases within 10 years, and that's obviously a concerning point. What about watchful waiting? Well, I'm not going to get deeply into this, but there have been some studies, and there's actually been some traction along the lines of doing watchful waiting in men for prostate cancer newly diagnosed. However, if you go back and look at the studies that we all look to, namely those by Johansson and Adolfsson in Sweden and the Danish studies, what you will find is that the endpoint of those studies was prostate cancer death. And there's an inherent problem with that because they either treated with surgery or they didn't treat. The men who they didn't treat and who developed alarmingly high PSAs, who developed bone metastases, who developed progression in the prostate region and obstructed the ureters, they were put on hormones forevermore. Those patients were treated with hormones forevermore, so it was a treatment. So it wasn't truly strictly watchful waiting. Now, if you look at that data, you will find that more men died in the watchful waiting group. However, when they checked the box, at the end of the study, they didn't die from prostate cancer. They died from heart attacks, strokes, broken hips. Well, guess what? What do hormones do in the long term? We like to use hormones intermittently, but if you use them forevermore, they're going to give you hardening of the arteries with hyperlipidemia, they're going to accelerate your diabetes, they're going to weaken your bones, and so what happens is many men will die from the side effects of hormonal therapy over the long term, but in this particular studies from Sweden and Denmark, they did not censor out those patients who were in fact treated. So that's why I say they're inherently flawed. Meanwhile, in the United States, they did do it a little better more recently, and this was a Medicare SEER study, almost 50,000 patients treated with radiation or surgery and did watchful waiting, and they found a statistically significant advantage in men who were treated with radiation or surgery. And in fact, the group that benefited the most was a group who were over 70 years of age or greater. Meanwhile, a Lancet study as of May of 2008 found that here in the United States we're enjoying a greater than fourfold increase in survival compared to the UK, a country where they do not treat and primarily watchful wait. And so, and again, that is mostly sustained in the older population. So it kind of flies in the face of the watchful waiting and the older data. So again, while that is gaining traction, watchful waiting, beware. Also, if you look at the recent life expectancies, they're getting longer and longer and longer. And this is for men. Women you can add a couple years onto that. But basically, a 70-year-old is going to have over 10 years, and even a 85-year-old can have nearly 5 years. And these numbers are growing. And so something to be concerned about if, for example, you're an 80-year-old and you have a Gleason 9 tumor, you got a fair life expectancy. Okay, so let's talk about advanced technologies. Because first, if you have prostate cancer and you've been treated, we got to pick it up. And this is just a schematic of your pelvis with the vessels and lymph nodes. There are tests which will specifically enumerate cancers which have gone afar, either in lymph nodes around the prostate or distantly. And Combidex and Cinerem, same. MRI it awaits FDA approval, so that unfortunately we can't offer it in this country, but it's done very well in the Netherlands, and many of our patients do travel to the Netherlands to have this done. The F18 FDG fluoride PET-CT we do have available here in the States, and specifically in Sarasota, where they have done more than any place in the country. And the C11 choline PET-CT, which was done at Duke, but again, we're waiting for its FDA approval. When we're looking for prostate cancer in the prostate, we think in terms of multimodality ultrasound imagings with either grayscale or color flow Doppler, and I particularly like the color flow Doppler methods. And I've really gotten involved with the dynamic or functional contrast enhanced MRI. I think it's superior to any other MRI available out there, including the spectroscopic MRI. The Combidex was first published in the New England Journal of Medicine, and this was a study in 1993, so it's 5 years old. I worked closely with Dr. Berends in the Netherlands, since again it's not being done on our soil. And what it's showing you here is that there are a couple of lymph nodes involved which were just not detected on any of our tests here. But this is a Combidex study, and in red these are lymph nodes. And there's a few down here as well. And this is important because you would just never have known this amount of lymphadenopathy above the pelvic area in this particular patient. With the initial Combidex study, 33 of 33 men were identified to have prostate lymph node metastases following a lymph node dissection or sampling, so it was 100% predictive accuracy. That has since been further analyzed, and the predictive accuracy is up to the 95-96 range, very high. We generally would say that if a patient has that high a prediction, then he should not be subject to lymph node dissection, because lymph node dissection does carry with it some morbidities, and you may even miss the lymph nodes that you're trying to get and get a false sense false sense that you do not have prostate cancer in lymph nodes to begin with. But again, this study does demonstrate the Combidex is enormous in terms of its ability to pick up lymph nodes outside of the prostate, in the pelvis, and in the abdomen. This is another test, the F18 FG fluoride PET-CT, which I don't have the slide, but it demonstrates a 98% predictive accuracy. As you can see, here's a spot right here which was not picked up on bone scan, and in the axial, here it is. And again, this is a patient with a tumor in the cervical spine. And interestingly, many men who have positivity on the F18 FDG fluoride PET-CT, the FDG will also pick up lymphadenopathy. Not as well as a Combidex, but it's pretty good. And I don't know if you can see it, but there are lymph nodes here in the pelvis which were not identified on any of the current studies. And again, here's a lymph node identified in the iliac region on axial, and here's even a lymph node in the supraclavicular region in the neck. And so we're finding that with more experience, and these were from the Sarasota group, with more experience, they're getting pretty good. And so for those patients who can't go to the Netherlands, this might be their next best stop if they happen to have a high-grade tumor, Gleason 8 through 10. What about the dynamic contrast enhanced MRI? Well, this is a neat study. It looks specifically for permeability, and we've come to find that cancers are very permeable to this contrast medium. And what this is basically showing you is what a standard MRI would show. This is the dynamic MRI, and this is a whole mount. This is after you remove the prostate, and showing the similarities of spots where it's showing. And what it does is it demonstrates both vessel permeability, which increases with cancer, and it also demonstrates increased cellular density, which is obviously a pathognomonic for cancer. And this is just an algorithm showing you how they get there with the high cellular density being more permeable. And here is a standard T2 weighted MRI, and here is the dynamic contrast enhanced. And you could see and start paying attention to how edgy or how to the side prostate cancer does become. This was a study which basically demonstrated, this was a multi-institutional study from Harvard and Austria and Israel, demonstrating that with a dynamic contrast enhanced MRI, there was upwards of 75% accuracy when showing that study, and then patients going to surgery and then doing the whole mount, meaning having the prostate in the pathologist's hand and seeing where the cancers were. And this is again showing just that, where the cancer was being shown here, and here is a whole mount showing it here. So very accurate test. I like it. And again, it's also nice to see it because it's just glaring. You know, it's red. It's just the colors they make it. But this is showing you neurovascular bundle involvement on the left side, so this patient would not be a good candidate for surgery. Another positive feature with this study is we've always wanted a study that could potentially differentiate cancers at an earlier point in time, whether they be real or not, because after, for example, radiation, a field I'm involved in, it often takes years to determine whether a cancer has gone away or not. And with spectroscopic MRI, they're 18 months, maybe a year. With other tests, it could be even longer. But with the dynamic contrast enhanced MRI, we're seeing that we could actually make conclusive statements sooner. This is a patient who was only on 3 months of hormones, and this was the tumor initially, and this is the tumor 3 months later. So that's important. This is a patient who has had a previous prostatectomy, so his prostate was removed, but here are some areas of cancer regrowth within the prostate bed, which is very important. Gives us ideas of where to zero in on, and specifically with newer versions of radiation, how you can intensify doses of select areas. What about colorful Doppler ultrasound? Well, this is interesting. This is a tumor in a patient who had previously undergone external beam radiation, and this is what you would see if you would measure the velocity of that tumor, because cancers don't, let me say, normal tissues or vessels don't do this. They pulse. They pulse with your bloodstream. Cancers do this. Okay, they don't pulse. They're stagnate. They're there. Okay, they may be active, but they're not going in sync with your normal circulating system. They're doing their own thing. And this is just showing you at the base in a sagittudinal image the cancer, which is at high volume. And again, if you just keep focusing on where cancers begin, right along the edge, and color flow and the dynamic contrast enhancement MRIs are somewhat similar. Color flow has a pattern of vascularity which is different, contrasted to the dynamic contrast MRI, which more or less has the permeability factor. So they are showing you a similar thing in a different way. And this is a very dominant lesion in a patient, the T3 lesion. With grayscale, you're just seeing hues of gray or black and white. This is a patient who has previously undergone seeding, and I specifically say elsewhere. The base of the gland is here, but we picked this area up, and that did prove to be prostate cancer with positive biopsies. This is a patient who, I commonly follow patients who've had prostate brachytherapy, and we may see something like this, which is generalized inflammation, which is no big deal. Those are small capillaries, and they're expected to be there. The gland has capillaries going through it. This is a perfect picture. You got the periurethral area, and that's the area where you would expect to have some blood flow, while around the area in the peripheral zone, you really don't see any color flow Doppler. These are actually internal hemorrhoids. This patient here is having a little more urinary symptoms because the periurethral area is a little hotter. He has more color flow there, just letting us know that there's some action going on in that area. And again, this is showing what a normal vessel in the prostate might look like with the bounding pulse. Okay, that would look the same as if you were to do a carotid ultrasonography. And this is a patient here who has an obvious left base lesion, status post external beam radiation. And again, a very dominant lesion, which may or may not have been picked up by grayscale, but it's distorting the capsule greatly. And a patient here who's showing the entire posterior peripheral zone being involved by cancer. Again, if you look harder, and I often say, you know, hindsight is 20/20, then you would notice it's darker with grayscale, but it's not so clear until you see it with the colorful Doppler ultrasound. This is a patient, again, with the nerve bundle involvement on the left side. It's the right side of your screen. And you can see where the peripheral prostatic capsule vessels here cross the capsule and communicate with the periprostatic plexus, in this case the neurovascular bundle. So this patient may not be a good candidate for surgery. This is a very interesting slide. On the left, this is a patient who had brachytherapy, and you can see the little seeds in the gland, and with grayscale you might just send the patient home and say there's nothing going on, but look at the color flow. This patient had a PSA of 0.1, by the way. I did his biopsies, and sure enough, these were Gleason 7, 8, and 9 tumors throughout. And so, you know, the PSA can be important, but the color flow Doppler ultrasound in follow-up we're finding to be extremely important and will predate the rise of the PSA. With color flow Doppler ultrasound, we also look in patients who've had their prostates removed, and fortunately this patient has no color flow. But what he does have is a prostate remnant, which is 10.79 cubic centimeters in size. That's a lot. And we're seeing more and more of this, and we're seeing more and more of it with laparoscopic and robotic techniques. Here you're seeing a patient with even seminal vesicles still involved, or still there. They should be gone after prostatectomy. And a patient here, this is right at the very lower fossa following prostatectomy, and it's hot. And this patient does have biopsy-proven cancer in the prostatic bed. So again, colorful Doppler ultrasound has really brought a nice tool to the way of following prostate cancers and evaluating for recurrences. So what does the patient do if his Combidex is positive? Well, here's a patient, and his lymph nodes here, he was actually already treated to the prostate, which is actually down here, and yet these red lymph nodes are identifying disease in the common iliacs and even the periaortic region, and he's been injected with a substrate, which is a ultra small paramagnetic, super paramagnetic iron oxide nanoparticle test, and this is what it shows. But what you can do is use some very sophisticated radiation techniques and recognize that while I'm showing you here the vessels and the lymph nodes, there's a lot going on around here. There's your kidneys and your bowel and everything else. And here's where you really have to step away from conventional radiations, not 3D conformal, not IMRT, not IGRT. You got to go beyond that. You got to go into dynamic adaptive radiation therapy where you're able to follow the movement of organs. And you have to be able to fuse an MRI Combidex with a CAT scan to put it in your treatment planning center, and then utilize other instruments like the dynamic contrast enhanced MRI or the colorful Doppler ultrasound to allow for DART, which is in essence the evolution of IMRT. As I say, IMRT, at least in my clinic, has become obsolete, and we've moved on to the point where now we can hit a moving target the size of a dot. We call them voxels, like a pixel on a computer or television screen, but it's space occupying, it's 3D, so it's a voxel. My cancer has returned following treatment. What to do? Lots of options. I think Dr. Treatment went through some of these. Prostatectomy can have external beam radiation, preferably with more advanced techniques even than IMRT with hormones. You'll often hear that, and again, I know this could become a urology, radiation oncology debate, but you know, patients are often told if they have radiation, they burn their bridges for doing anything else, and that's not the case. You can see a patient who had an external beam, he still has prostate brachytherapy, cryosurgery, which Dr. Barzell will be talking about. He could have HIFU, biothermy, and prostatectomy by a world-class surgeon. A patient having prostate brachytherapy can have salvage brachytherapy, he could have cryosurgery, HIFU, biothermy, prostatectomy. But you know, this group of patients rarely has local failure. It's not so common. And of course, there's hormonal therapies, there's chemotherapy, and then going back to the watchful waiting and their active surveillance. What went wrong? A patient had his prostate removed. Why is my PSA rising? I don't even have a prostate. Well, it's all about location. As I was showing you earlier, cancers begin in the peripheral zone on the edge, and the prostate capsule is very, very thin, and it just doesn't act as a good barrier for the dispersion of cancer cells outside the prostate capsule. And this is again showing you where cancers begin. It's all about location. You know, it's edgy. You rarely find tumors in the central transitional zone of the prostate. And again, this is with the dynamic contrast-enhanced MRI, again showing you that edginess, the fact that cancers do begin in the peripheral zone. And this is a whole mount with dyes which are used status post removal of the prostate, gentian violet or Indian ink, and it's just showing you that there's a positive margin. Some history, Dr. Moore back in 1867 said that radical prostatectomy actually violates the principle of surgical oncology. He said that sufficient normal tissue should be removed so that the tumor itself would not be seen during the cancer operation. It would almost be like saying, well, there's a pit in this orange or lemon, so I need to take out the whole orange or lemon, meaning you don't see the pit. And weighing in was Dr. Halstead, a well-known surgical oncologist at Johns Hopkins, who said that wide surgical margins are necessary to excise the cancer and that cutting through cancerous tissue may liberate cancer cells and contaminate the normal circulating blood system, perhaps beyond the level which the body can deal with. And that was in 1895. And he went on to say that if you were to truly do a cancer operation with prostatectomy, you would have to do a total cystoprostatectomy, removal of the neurovascular bundles, and an anorectal resection, also we call a pelvic exoneration, leaving the patient with a permanent colostomy, urinary diversion, and complete erectile dysfunction. And owing to this, prostate cancer removal has evolved into a procedure looking to preserve urinary and bowel continence with sexual function, but you really can't live by the codes of cancer surgery with the prostate unless you're willing to remove the bladder, remove the rectum, the urogenital diaphragm inferiorly, and the neurovascular bundles. Because of this, Dr. Halstead said, by any of the above criteria, modern prostatectomy has evolved into a very poor cancer operation, and that one would expect to provide very poor local control. Prostate is way down here, and you would have to remove all of that. Here's the prostate. You'd have to just remove all of that. It's just not done. It's not being done. It's not going to be done, and that's the problem. And for those of you urologists who want to shoot me off the podium here, don't worry. I'm going to come down on radiation as well. So what about prostatectomy in contemporary times? This is scary, very scary, because these are patients who had positive margins and negative margins, but over time, it's a linear fall off. It's just a shelf. I mean, Quite patients have to ask, well, I'm failing at the same rate in my 5th year as I am at the 10th year, as the 14th year. It just keeps going. So patients keep failing. And if your PSAs are higher than 10, not doing very well. This would be the perfect world. These are the patients being treated 100%. And if they were cured 100%, the line would go out like this over time. Okay? But unfortunately, it doesn't look that way. So as the PSAs go up higher, so do these fall-offs. And what that basically is saying is that patients are falling into a failure mode over time with their PSAs. And this was these are very recent studies, and I'm not picking shabby institutions. This is Johns Hopkins, Indiana University, Sloan Kettering, Northwestern University. It's just basically showing you that the numbers are less than 50% in patients having radical prostatectomy with PSAs greater than 10. What about Gleason 8 through 10? Same thing with surgery. And again, Gleason's 8 through 10, picking top institutions, Mayo Clinic, Northwestern, Johns Hopkins. Really bad numbers, 27%. The highest you get to is 47%. This is unacceptable. What about patients with low risk, intermediate, and high risk? I first showed you that slide, and these guys are doing okay, but even intermediate is falling off quite substantially, and high risk dramatically. This is very interesting, reported at UPenn by D'Amico, showing you that in a patient who has a positive biopsy with 33 to 50% core involvement, he's already falling off. And if it's 50% involvement, it's less than 50%, just in one core. Perineural invasion appears to be another ominous thing, as reported by Johns Hopkins and the Mayo Clinic after surgery. So should you be concerned? Yes. What about the Da Vinci robot? Is it bringing us something better? Not really, at least not by contemporary studies. In 2008 demonstrated that there was a 3-fold increased failure rate with the Da Vinci robot, reported in the Journal of Clinical Oncology out of Harvard. And more recently, even than that, at Duke University, patients who underwent robotic surgery had significantly higher levels of dissatisfaction and regret than patients undergoing radical retropubic prostatectomy. Well, maybe their expectations were just higher, that's all. And maybe these patients didn't have enough experience, that's all. I don't know, but this is what the data is showing. What to do? Well, there's a real problem after surgery because radiation likes to work in an oxygenated bed. It depends on having those oxygen molecules coming around to create free radicals to kill the cancer cells. But in a prostate surgical bed, it's surgically devascularized, denuded, and so there's not a lot of oxygen there. Meanwhile, salvage radiation doses are suboptimal, so what can you do? Well, you can increase the doses substantially using higher-end equipment, and you can combine radiation with hormones to exploit that synergistic or super additive effect, meaning 1 + 1 equals a bigger number, 3 or 4. Is this as good as it gets? Well, this was thought to be as good as it gets by Dr. Ansher at Duke, and showing that as time went on, after a patient who failed from prostatectomy and treated with radiation and salvage, that he could perhaps salvage 50% in the long term. How do you improve upon that? Well, first of all, we have to determine where is the cancer, and importantly, if a patient's Gleason score was less than 7, no liminal sentinel vesicles involved, negative lymph nodes, PSA detectable only after a year after surgery, and a doubling time of greater than 6 months, he more likely than not has recurrent disease, and you could probably take care of him and cure him. These are studies demonstrating as time goes on the number of PSA picked, meaning after your surgery. Don't wait too long. As you see, the numbers keep getting higher and higher, with 74% being by Dr. Zalewski at Sloan Kettering. And even in that subset, he found that he can cure upwards of, well, actually 90% or upwards if the PSA was 0.4 to 0.6. So again, the word is don't wait too long. Don't just sit on your PSA, because when that happens, the salvability of cure is low. And Dr. Myers already commented on this. Interesting study, because they looked at immediate versus radiation treated when the patient failed. And interestingly, there was a dramatic improvement in patients being treated adjuvantly, meaning they were planned to get radiation. Okay, not only when their PSAs rose. But another take-home point of this was a sentinel node IMRT for prostate cancer showed that most of the cancer lymph node involvement was actually in the true pelvis and in the upper pelvis, and speaks for treatment of the higher pelvic region. I love this study because what this is showing from UCLA is that patients treated with surgery alone, they're only about 15% cured at over 10 years. This is Gleason 8 through 10 tumors. But if they got postoperative radiation to the whole pelvis, look at that, 65%. It's dramatic. So this was a study at Stanford. Again, they combined hormones with radiation and found that there was a statistically significant benefit by doing that in an adjuvant fashion. And there's a mountain of studies growing in multi-institutional ways showing that radiation plus hormones is better than one or the other alone. So the conclusion is that PSA matters, don't let it get too high, dose matters, you have to treat with a higher dose. Adjuvant is better than salvage. Time to relapse really matters. The grade that you initially had matters. And you must use more sophisticated radiation to decrease the toxicity and exploit the advantage by combining with hormones. What do you do in contemporary times? Should you be concerned after radiation? How does radiation fare? What about if patients have elevated PSAs? Again, our perfect patient, perfect graph. Same thing. As PSAs get high, patients fail. Again, University of Michigan. As PSAs get high, patients fail along with their clinical stage. What about if they have intermediate to high-risk disease? Well, here's the intermediate, here's the high risk, so they're failing. Not quite as high as surgery, but it's there. And that's just, I can't even read it. But it basically is, what it's basically saying is, how do you avoid recurrence? Well, in this group, these patients got hormones. They received hormones, and they had high-risk disease, or intermediate to high-risk disease. Now we're at least starting to look at higher numbers, 40s, 60s. I mean, we're getting up there. So there's definitely an improvement in combining radiation with hormones in the more contemporary studies out of big institutions. But again, going with radiation, just stratified by percent of positive biopsies. This patient may say only 1 out of 6 biopsies were positive, but in that biopsy, 80% of the core was involved. It's important, because if he was there, then he's in that red, which means that he's falling off, he's failing greatly. And using IMRT, can we get better? Well, unfavorable, intermediate, and favorable. So again, the unfavorable and the intermediates are not doing that well. So should you be concerned after radiation? Yes. What can we do? Well, maybe enhance our radiation abilities beyond IMRT with increasing dose levels, because dose really matters. This is a recent Dutch study and demonstrating a statistically significant advantage with using 78 gray versus 68 gray, and I would argue you got to go much higher than that. MD Anderson showed the same. 78 gray versus 70 gray, and a statistically significant advantage with PSAs over 10. Again, at Sloan Kettering, from 64 to 75 to 81, they just really jumped up in terms of curing their patients. And using even higher dose levels at Sloan Kettering, this is an 8-year study, they were able to even achieve a 90% with a low risk and 70% with intermediate, and the 60s with high risk. So dose definitely matters. I don't know if I have time for this. Following definitive radiation, there are salvage methods, including radical prostatectomy, which, let me just say, is about 50%. And with brachytherapy, let me just say, it's about 50% properly selected patients. Here's my own data. It's about 50%. Interestingly, though, in salvage brachytherapy, after primary radiation failure, up to 98% of the local recurrence may be locally controlled, and 5-year freedom from relapse is approximately 50%. And with careful selection, meaning if you don't wait for the PSAs to get up to 10 and you treat them with low numbers, you can start looking at numbers over 80%. And I just can't, I'm not going to have time for this. So how do brachytherapy-based regimens measure up? That is combining radiation with brachytherapy. So you're using the external radiation, and then you're zeroing in with brachytherapy. And I would argue you can also zero in with more sophisticated types of radiation, IMRT, IGRT. With high-grade cancers, again, you'd love to have this, but you're not. but you are getting finally some plateaus in the curves. And that's important for Gleason 8 through 10 tumors. And it's reproducible, as you can see. PSA is greater than 20, you're getting plateaus in the curves. This is my own study in Seattle, who've been at it for a long time. So how do these patients fare? Well, they're starting to fare pretty well. Intermediate, in my study, 89% at 16 years, 74% at 16 years for high-risk disease. And again, reproducible. This is very important. 16 years, 80% of the patients with Gleason 8 to 9 tumors are being cured. 16 years, I think you have to say cure. And again, it's reproducible. These numbers are, here's an 89% here, there's an 80% here, 60. I mean, it's up there. It's not the numbers we were looking at before, 10 to 40s. And again, this is combined radiation with seeding, and again, looking at 16-year data for just strictly high-risk disease, and I published 74%, and with the longest data, 16 years, and at 8 years at Mount Sinai, 83%. And these are just generally reproducible studies, and you really like to see that. You're not the only one to say it. So is locally advanced high-risk prostate cancer incurable? Absolutely not. And here it is right here. It's showing you that recent studies are demonstrating that we can get to that, not perfect curve, but we're getting close. And these were high-risk patients. This was the one that is most commonly cited by surgeons, D'Amico. At the Brigham, he used MRI to guide his brachytherapy, and it was just a failure, but it is the most commonly cited brachytherapy paper. Okay, I'm going to leave you with this. This is the first look at our 16-year data at the Tottoli Cancer Center. It's been accepted for ASCO. And this is a joint study with the University of Washington in Seattle with 321 consecutive patients treated by one author, myself. These are patients having intermediate to high-risk disease, and patients were really held to very strict boundaries in terms of cure, less than 0.2, Nader plus 2, and Astro consensus. Those are the three consensus studies or methods to determine if a patient is free of cancer at length. And the reality of it is we used all three, so we just didn't want anyone to say, well, you didn't do this, you didn't do that. In the patients who did fail, because we didn't cure everyone, they were subject to saturation biopsies on all failing patients. Not a single one came back positive. The biochemical data was independently re-reviewed and analyzed by Dr. Wallner at the University of Washington, while all the slides were independently re-reviewed by Dr. Larry True at the University of Washington. And as you can see, these patients had an average almost of a PSA of 20 and a mean PSA of 16.4, and 52 of the patients had Gleason's 8 through 10s, and most had Gleason 7 through 10s. Many had Gleason, clinical stage T3A. So the results are demonstrating that 89% of the intermediate group are free of cancer at 16 years, 74% having high-risk disease with an 86% cancer-specific survival. That means prostate cancer, that they survived prostate cancer. They didn't die from, as I was saying, with the hormonal studies where you can die from, heart attack or stroke. But importantly, the absolute risk of failure fell to 1% beyond 5 years after treatment. So this is the data, and it's getting close to that with high-risk patients. PAP, I've identified numerous times, I've published extensively that it's as important, if not more important than the PSA, as being a prognosticator for surgery. And while hormones conferred no statistical advantage in my patient population here, understand that the patients who did receive hormones had the worst, absolutely worst presenting features, meaning PSAs of 50, 60, Gleason scores of 9, and everything was bad. And this is just showing you that over time, patients are free of cancer, and they really don't have to worry beyond here because there's just no further failures, at least for now. While the toxicities are extremely acceptable, not a single patient developing rectal ulceration. And as I said, no patient had a pathologically documented local failure who did fail, and I mandated saturation biopsies on his prostate. So the conclusion is that with these patients having intermediate to high-risk disease, using strict NADRs, meaning strict standards of cure. We've done it. And despite the aggressive nature of the study, no local failure had been documented. And that's not to say that in the future others won't be, but very importantly that it's encouraging to find that at 5 years we've decreased the failure rate to near zero, or that's what we're seeing. And this, coupled with numerous other studies, do suggest that brachytherapy-based regimen should be considered the standard of care in this group of people. I love to show this because this is at Sloan Kettering. We actually started working at this in 1989, and we found that patients who were properly implanted, they did well, and they didn't develop disease elsewhere. You know, back in the day, in the 70s, Dr. Will Whitmore had performed brachytherapy at Sloan Kettering, got a bad rap because they were performing them in an open retropubic way, not the transperineal way. But we came to look at those studies and found that most of the seeds were not even in the prostate. But for those who were, those patients actually did well. So I guess this would just be based on data, bottom line for treatment-based curability. For a low-risk group, IMRT equals brachytherapy equals prostatectomy. So you'd have to kind of decide which one is best for you. For intermediate risk group patients, I would say sophisticated radiation techniques, especially with hormones, are at least as effective as prostatectomy. I'll actually say are better. And that brachytherapy-based regimens that's with supplemental radiation appears superior to prostatectomy. And basically that's what that says. And this is the references for those of you, I think it's in your handout, want to check my fact-checking. And new does not necessarily mean better. What I've just shown you is an evolution of what started 2 decades ago with external beam radiation and brachytherapy, and the continuing of pushing the envelope of those two. However, this represents everything that's out there, from all kinds of swanky names to newer types of treatments. You'll hear about cyber knives, and I've mentioned Da Vinci, and soon there'll be a Picasso and something else. I don't know. But the reality is, if you're interested in this chart, we can give it to you, and it'll kind of describe each one. And that's it. Thank you.